welcome to the Hope and Healing Center. I'm so glad you all could be here. I want to introduce our speaker this evening, Dr. Thomas Kent, recognized by U.S. News and World Report and Castle Connolly Medical Limited as among the top 1% of doctors in the nation in the field of neurology. He is also the Neurology Care Line Executive at the Michael E. DeBakey VA Medical Center and the co-director of the VA Epilepsy Center of Excellence located at the DeBakey VA. A stroke specialist, Dr. Kent leads the acute stroke team at the DeBakey VA, and he's also a professor of neurology at Baylor College of Medicine, director of stroke research and education, a member of the Translational Biology and Molecular Medicine graduate program, and an associate editor of the Translational Stroke Research Journal. Welcome.
Okay, there'll be a quiz on if you can understand half of that. Thank you for the invitation, and thanks for coming out. It doesn't seem like maybe the most uplifting topic, but I'm going to try to make it a little fun for you. I am at the VA. I haven't been for most of my career, but I did want to end up my career there. You've seen in the press probably a lot of negative things about the VA lately. It's too bad because hospital itself is great. It's a shame what's happened at a national level, but veterans liberated my family in Hungary, and so I wanted to give back to them, and that's why I'm going to continue to work there at least the rest of my career. But I'm also at Baylor. I do a lot of research, clinical research, basic science research. I do talk to lay audiences a lot. I'm going to throw in a fair amount of images and maybe some science, so there are times you can fade away, and then I'll try to bring you back. So stroke is now the fourth leading cause of death. It used to be the third leading cause. It's going down, which is good. The numbers are going up, however, as the population ages. It is a disease mostly of aging. We'll talk about other causes. Most strokes are first strokes, but if you have had a stroke, then that does increase your chances dramatically for another one. So that's the time to really work on prevention. Please interrupt anytime. Don't hesitate to do that. It remains the leading cause of serious disability in this country for the moment. Maybe degenerative dementias will take over after a while, but at this point, stroke survivors do end up with some disabilities. So there's two kinds of strokes. The one kind is where the blood vessel is blocked and no blood gets to an area of the brain. And the other kind is where the blood vessel ruptures and causes bleeding into the brain. They cause kind of slightly different things. One can lead to the other, as we'll talk about. Most strokes are the blockage kind. Fewer strokes are the bleeding kind, but those tend to be more severe, and people tend to die more often from those. So I guess I have a pointer, maybe. Does this work as a pointer? Okay, there you go. So the blood vessels go to different parts of the brain. This is the most common area. This is the language area of the brain. Why is it the most common? Nobody knows for sure, but human brain doesn't have any more blood vessels than a mouse brain, but it obviously has a whole lot more area to supply, and our language area is one of our biggest areas, and so it's still supplied by just one blood vessel, even though it does so much function. Yes?
I see the picture on the right, the language part of the brain.
Right.
I see the picture on the left of the whole brain.
Yes.
I don't see where the language part is.
Right, it's not mentioned, but this is the main artery that goes to that area, and these are the branches, and this would be that area right here. It's the middle cerebral artery territory, called the middle cerebral artery. Cerebral artery, right. That's the most common place to have a stroke. Yes?
Is it on one side or the other?
It can be either one side or the other. Most people's language is on their left side, not everyone, but most people's. So if it's on the left, then it would affect language more than if it was on the right. The right side, people use to kind of decide where they are in space, and a stroke there might be even a little bit harder to rehabilitate from, even if your language is intact, because you're just not sure what's going on in space, where you are in space, and something we call neglect.
Long time ago,
Uh-huh.
I thought that if you had a stroke on the right side of the brain, it would affect the left side.
That's exactly right.
Is it
Still the same, yes, still the same. The brain crosses for some reason. So we have big vessel strokes, like the carotid artery. Okay, that's very common, and we'll talk a lot about that. We have what are called mini strokes in small blood vessels deep inside the brain, and we'll talk about that. Too. Mini strokes are confused a lot with what we call transient ischemic attacks, but we want to make sure that we understand the difference when we leave here. So a transient ischemic attack, or what we call TIA, is brief, usually minutes, 5 minutes to an hour. Sometimes it can go longer, but you recover completely from that TIA. Unfortunately, because people wake up with a leg that's asleep or an arm that's asleep, they think it's going to go away, and it does go away, but the problem is that it's a warning sign that something is wrong. And now we know, over the last 5 years, tremendous amount more knowledge about a TIA, that if you have a TIA, you have an increased risk of stroke, but it's going to occur in the next few days, okay? So it went away, you're going to go back, you might call your doctor, get an appointment in a week or two. Between that time and your visit, you have a stroke, right? And we'll see lots of examples of that. So probably what happened was we all have our blood clot dissolving chemicals in our body. Probably a clot formed and then it dissolved. It was able to be dissolved, but the next time that doesn't happen, and then the stroke occurs. So you may have numbness and weakness. If it's just numbness, it's not as ominous to us. It doesn't indicate a large territory, but if there's any sudden weakness or sudden problem seeing or sudden problem with speech, confusion, sudden onset, strokes are sudden onset, that's much more worrisome to us, and that's something that you should take care of very quickly. Get medical help right away, because the most common cause of a TIA that causes a stroke is completely preventable, and that's a plaque in the carotid artery. Hardening of the arteries in the carotid artery can be treated. It can be treated the next day. Sometimes we treat it that night with either surgery or a stent, and that can prevent more than half of the follow-up strokes. So the question is, how about blood thinning medicines? So in between, it is not definitive, but in between the TIA and the surgery, we will put you on blood thinner medicines. Other people may put you on a lot of aspirin-like compounds, but it is not long-term prevent the stroke. It's sort of an interim thing, okay? Without treatment, the risk for stroke is elevated for months, at least 3 months. If you make it past 3 months, we're probably not going to do anything with you because you made it through the hard time. We're going to leave you alone and leave that artery alone and just deal with all of your risk factors. So take advantage of this warning sign. About half the people have it. Half don't, but half do. So what are the risk factors? They're very similar to heart disease. In fact, the most common thing that happens to somebody after a stroke is, unfortunately, a heart attack. There's still 2 separate diseases treated by 2 separate specialties. They're merging a little bit, but diagnosing a stroke, treating specifically things related to the stroke, really is the purview of neurology. Not that we need more business, but it really is the best way to get that taken care of. 5% each year, yeah. Not a same person, but you have a chance every year of a 5%. Yeah, you have one, hopefully you'll get it treated and you won't get another one. We talk about annual risk of things. That's the way doctors think about it. So high blood pressure is a huge factor in stroke. It's probably the #1 biggest risk factor. And it's long-term. It's not sudden, you get upset and your blood pressure goes up. That's not what we're talking about. Not after maybe age 18. The young kids, when they unfortunately take a drug that stimulates their blood pressure, goes way up, they can have a stroke from that. But that's not going to happen to people our age. So it's long-term, untreated or poorly treated. Diabetes is a big risk factor for all kinds of strokes, okay? Smoking alone is not a huge factor, but if you have one of those other factors, it multiplies. So 5 times 2 is 10. 10 times 2 is 20. So it just goes up hugely if you're smoking and have one of these other problems. If you stop, you rapidly reduce your risk. So you can make up for that. Obesity, sedentary lifestyle, about 2 times increase. The more sedentary we are, the more chance that we can have a stroke. In fact, being very active reduces your stroke chance by about 50%. It's a huge factor, maybe as much as anything your doctor is going to do for you. So there's certain kind of heart disease that's a risk factor. The most common one is atrial fibrillation, the problem with your heart rhythm. It's very common. It may or may not indicate underlying heart disease. People with mechanical heart valves, they can thrombose, so they need to be on blood thinners. If they're not, you can have a stroke. Heart failure, because the heart's just not pumping that well, a clot can form. When blood moves, it doesn't clot. When it's not moving, it clots. So heart failure just can be a risk of stroke. Not a huge one, but enough that we worry about it. Family history, there's some genetics for strokes that we're discovering. Still very difficult to find a gene for stroke, but there is some family history relation, particularly to the kind of stroke that you may get. If you have the bad cholesterol that's high, the LDL, that is a big risk factor, especially if you have diabetes. So that's one of our big targets now, is to reduce. Neither one. Either 1 or 2 diabetes, both of them are risk factors for stroke. So, diabetes, what we talked about, 5 times the risk of stroke, but the latest information we have is for years, people are what we call pre-diabetic. The way I think about it is everything starts to go up, okay? Your weight goes up, your blood pressure goes up, your cholesterol goes up, but unfortunately your activity goes down. So this is a pre-diabetes. You don't actually have diabetes defined kind of with blood tests, but you're getting there. We now know that that pre-state doubles your risk of stroke. And just this year, new research that went on for about 10 years shows that one of the diabetes drugs, I'm not offering it, there may be others just like it, but this happens to be the one that was studied. If you're pre-diabetic, reduce stroke and heart attack by 40% in those patients over not taking this medicine. So I'm actually writing an editorial on this, so I'm reviewing all the literature. I'm not sure that it's going to change practice, but it probably will. You'll probably see practice change. If you see your doctor and you say, I think you've got maybe this, let's try something. See if you can tolerate it. That may happen. Okay, age and sex, that's not a different talk. Okay, we'll talk about age and sex and stroke. We used to say gender, but gender apparently can change, so we don't say that anymore. We talk about age and sex. Okay, so stroke risk increases with age. Stroke more commonly occurs in men at most age groups except young women and older than 85. That's when women start having their strokes. And it's because they delay hardening of the arteries because of estrogen and other reasons, and then as it happens, starts at an earlier age. So they've had this big, long period of time. And then young women, oral contraceptives, smoking, pregnancy can be stroke. So there's some things that happen uniquely to younger women as well that increases slightly their chance of stroke over young men. Okay, sex and stroke, again, not a separate talk. So women have their strokes at older ages. Again, we talked about young women. Fortunately, when women have their strokes, they're more severe, but they respond to treatment just as well as men. But we expect them to be a little bit more severe when it happens. Right, yeah. It has to do with kind of the redundancy in the brain. Okay, so let's spend a minute talking about prominent people who have had a stroke. Okay, for some reason, lots of our presidents have had strokes. John Quincy Adams, the first one, not sure what his risk factor was, but he had a stroke, not a severe one, and then boom, had a severe one which killed him. So we'll see a pattern here. We'll see a pattern. John Tyler was not in the best of health. He had what sounds like a TIA and a kind of TIA that's unusual and people don't think of it as a TIA. It's in the back part of the brain. So there's a separate set of blood vessels to the back part of the brain. And that controls things like your eye movements, your face, but it also your balance. And when your balance gets affected, you start getting nauseated. You know, if any of you have had an inner ear infection. So our job is to try to tell an inner ear infection or an inner ear problem from this. Well, what he had is what's called vertigo, imbalance, and weakness. So he had 3 different things happen to him. Actually, it happened to him repeatedly. And then, boom, he had his big-time stroke, which ended up killing him. Of course, he had I think they recommended bleeding after the last one, and then he died, I think, a few hours later. So Millard Fillmore, the best can be said about Millard is that he was very sedentary. Okay, he did not get around very much. And he had 2 strokes in rapid succession and died from the second one. Andrew Johnson, I think the best can be said about him, and he loved mint juleps and whiskey. In fact, some suspect his inaugural speech he may have imbibed a little bit, since apparently it makes no sense to anyone. Again, someone had 2 rapid strokes in rapid succession and died of the second one. Okay. Chester Alan Arthur, another fine living gentleman. What we know of him, he's had heart disease. So he had the combination of heart disease, not sure what kind, and then his fatal stroke. Woodrow Wilson, now he was never healthy, and he smoked heavily. He actually had a blood clot in his eye as his first manifestation of hardening of the arteries. Then he suffered speech loss, I think before he was going in front of Congress. Then 2 weeks later, he had permanent paralysis. He did serve out his term, but I think he died in office, I think he died like the last day of his presidency, something like that. Oops.
I guess they didn't have Lipitor in the Senate president.
That is the message. They did not, but they did for FDR, okay? So FDR, they did have. He was a heavy smoker, and his high blood pressure was never controlled. Okay, his doctor, one of these famous presidential doctors, just did not control his blood pressure. So he had mini strokes, a number of them, and then that last mini stroke turned into a big hemorrhage, and he died from that in 1945 in office. Eisenhower, we all know he had heart disease, very famous, went to the famous heart doctors. He had a stroke which left him unable to speak. In 1957, he recovered from that, but his heart attack eventually took him. Richard Nixon is the only president that had what we would consider current secondary prevention for a stroke. He had atrial fibrillation. He was on Coumadin, which is the mainstay of treatment for that. We don't know how well he was controlled, but he had an ischemic stroke, not a hemorrhagic stroke, and it ended up being fatal in '94. So I remember this. I remember when he had his stroke, and he was alert and awake as he was waving and being taken back into the hospital. I don't think he could speak, but he could wave. And then within 3 or 4 days, he died, and what he died of is brain swelling. So after the brain is injured, it swells. Just like a bruise, any injury in the brain, any injury in the body causes swelling, no matter where it is. Yes. Stroke. The stroke is a brain injury. That's what I mean by the injury. What was his brain injury? That was his stroke. So he had a clot in his heart, presumably from his atrial fibrillation, and then that went to his brain and caused his stroke. Right. That's how that happens. That's how that goes. A clot comes from the heart due to atrial fibrillation. The clot can go anywhere, but its first place it sees is the vessels that go to the brain. So his brain swells, and as you swell, if it's uncontrolled, it causes so much pressure. In skin, it can go out. You get a big lump, okay? If you have a bruise in your knee, the cartilage gets really painful. But in the brain, the skull keeps everything in, and the pressure got so high that you end up dying. He actually had a living will, and it said that he did not want any heroic measures. But we'll talk about at the end that maybe something can be done to save people now that have that. Yeah, yes.
I think you said the hemorrhagic rather than the ischemic.
are ischemic.
where you require the clot busting.
Exactly, right.
You hear often that that needs to be applied within 2 to 3 hours.
That's right.
Still a guideline that's
So-
valid.
Great question about when to do that, and we'll get to that in a little bit. It's now up to 4.5 hours. And the latest this year is we have 3 or 4 studies came out that with a catheter to actually go up and get the clot, we can go out to 6 or 8 hours. But the best results are still the sooner the better. 95 is when the clot busting study came out. And in fact, he could have entered that study. They were offering that study to him. But because he had declined they just decided not to, because he had, for whatever reason, had decided he did not want any heroic measures, which may have happened, which may have been needed had he gotten that drug. But he was actually offered that drug.
If your brain swells, is there anything you can do?
Yes, there is. There is. There's medicines you can reduce, and we'll talk about that. We'll get to the brain swelling in the end. And I want, this is new and still not getting around very much. Gerald Ford actually was talking to reporters when he had his first mini stroke. He had lots of hardening of the arteries. Ended up getting heart treatment in 2006, and he died of probably both stroke and heart disease later that year. But he lived a pretty decent life, 93. We still think that's young, but we'd like to extend that a little bit. So these are the ones with documented strokes. Bill Clinton, has heart disease, but I think the kind of strokes he had were different than what we're talking about here. Different kind of strokes. That's a joke. That's a joke about Bill Clinton and his escapades. Okay, I won't go into that anymore. I'll explain it later. Okay. I'll explain that later. Okay, not just American presidents. Winston Churchill, multiple strokes. He was depressed most of his life, apparently. Big-time drinker, smoker, had his first heart attack in 1941, and then a series of strokes, the last one fatal in 65. They did their best with him, but I think he was a little bit grumpy and didn't comply very well with his medicines. Good old Lenin, we don't know much other than he had his first stroke in 22 and he died in 24. Then we come to Stalin. So Stalin was a smoker, hypertension, had his first stroke in 45. Then he had a massive hemorrhage in 53. He couldn't speak and eventually died of brain swelling. Now the interesting thing with him is that the speculation is somebody may have poisoned him with Coumadin, okay, because he had blood everywhere, blood in his stomach, blood around his heart. He was bleeding everywhere. But this, maybe he just took too much by accident, I guess. But that's the suspicion. Other prominent people who suffered a stroke. So this is kind of interesting. Is actors and actresses. Okay, 7% of all Oscar winners have died of a stroke, and there's an article about this. What could it be? Average age is a little bit younger, although in women, again, my favorite, Lauren Bacall, died of a huge stroke at kind of that age that it happens at 87. But some younger women, some of the real stars. One speculation is, how much they smoked. All those old movies, even the women were smoking. And, maybe that just took its toll eventually on them. Now, every movie, they're not smoking cigarettes, they're all smoking marijuana. We can't turn on a television show without something about marijuana. So I'm not sure they're actually smoking it on set, though, which I think they did in the old days, but they might do it. So we don't know what the long-term consequences of that, but fortunately they don't smoke as much in Hollywood as they did. So one I wanted to just spend a little bit about is the former president of Israel, Ariel Sharon, who went into a coma from a massive brain hemorrhage, and he was a really hard case. Israeli medicine is phenomenal, as good as American medicine, but in his case they actually came to American doctors for advice, and it was terrible advice. It was really bad advice that they gave him. So he had a bad heart, but he also had bad blood vessels in his brain. He had a condition called amyloid, which is rare, but it exists, especially if you had long-term hypertension. So because of his heart disease, they thinned his blood, but then he had a massive hemorrhagic stroke, went into coma. I don't know if he died, but for years he was being maintained in a coma. But what we can now do is test if you already have these little micro hemorrhages in the brain, if your vessels are so bad that they may bleed. We do it for every stroke patient, even before we put them on aspirin now. That was available then. In fact, unfortunately, they knew he had that, but they still went ahead and did it. So it's really unclear why they were advised to do that. But if you know someone that's had a stroke or you've had a stroke, ask and see if you can get it. It's done with a routine MRI. It's just a little different pulse sequence to look for hemorrhages. Okay, questions, people? Let's go to the different kinds of strokes. Let's spend a few minutes on that. So the job of your doctor is to figure out what kind of stroke you've had. So if you have a stroke or you know somebody's had a stroke, you need to know what kind of stroke was it, because stroke isn't, as we already learned, is not all the same, okay? Or if it's a TIA, what caused that TIA and what are we together going to do about that? Okay, so the first kind we're going to talk about is what traditionally strokes, not a TIA. A TIA could indicate a huge problem. Okay, so a TIA is not a mini stroke. A mini stroke is actually a small stroke. It's very small vessels in the brain, so they don't cause as much damage. Each one itself doesn't cause as much damage. But what we know now is that you come in and you have a stroke symptom like your arm is weak, we do an MRI scan, we may very well see 10 prior mini strokes that you didn't know about. That's about the average, that when you come in to see us, we'll see about 10 that you didn't know about.
What part of the body do you do the MRI on?
Of the brain. MRI of the brain. Okay? This is all brain stuff. We know that about 5 million people have a silent stroke. So these are what we call silent strokes. You didn't know you had one. Typically, when they do end up causing symptoms, it's either motor weakness, sensory loss, or incoordination, or some combination. You won't lose your ability to speak. You won't lose your ability to think. It'll be more of these basic functions that you have. The big vessels go to your thinking part. The little vessels go to your movement part. So on the surface, it doesn't seem to be as severe a stroke. Yes?
Explain motor weakness, sensory loss.
Right, motor weakness, you can't move your arm. Sensory loss, you can't feel your arm. Incoordination, you can't use your arm. Okay, and those are sudden changes. That's a sudden loss of those abilities. Could be one or all of those. But not thinking, not language, not thinking, not perception, not your higher order function. They're highly recurrent, about 10% a year chance of another one of these. So we consider that high recurrence. And of course, as you get more, you'll get more and more disability. And the most devastating complication is these little strokes can turn into a hemorrhage, and that's what happened to FDR. That's why we use him as an example of this. More common in African American and Hispanics, but it can occur in all races, Caucasian as well. And 2 out of the 3 have the usual diabetes, hypertension, smoking, cholesterol as a risk factor. A third don't. In that case, it's probably something to do with genetics. So stroke in the large blood vessels. We've made the most progress in stroke in the large blood vessels. This is more common in Caucasians. This is the disease mostly of Caucasians. It may start early in life. You don't have any symptoms, especially if you have diabetes. But the good news is, if it's in the right vessel, particularly the carotid artery, it can be fixed. That plaque can actually be removed, or a stent can be put in that opens it up just like the heart. In the heart, they don't remove the clot. They put stents in, move the plaque. In the brain, it's big enough that the vessel is big enough that you can remove the plaque. And that cuts more than half your chance of a future stroke. It's just this hugely important treatment. But we need to do it within 3 months of your stroke, or as we talked about before, as soon as possible after your TIA to prevent that big stroke from happening.
Would you like to tell us what the large blood vessels?
The carotid artery. I showed you that at the beginning. The carotid artery is the main one we're talking about.
Not in the leg.
Yeah.
Just carotid.
Carotid is the one that we can operate on. It can also happen in the big vessels in the back of the brain. Those you can't operate on. They're too delicate. But the carotid, fortunately, as we said, is the most common cause, and so the most common target that we have for a treatment. So the first thing we'll do when you come in and you've had TIA or a small stroke is we'll look at your carotid artery and we'll assess whether we can do something about that. And that should happen within the first hour of your being in the hospital. So cardioembolic stroke. This is a fancy word for a clot coming from the heart and into the brain. Okay? Clot forms in the heart when there's certain underlying heart disease. Atrial fibrillation, where the part that pumps the blood just does not contract well enough. It never makes these really good contractions, and so its blood stagnates and forms a clot. When blood isn't moving, it forms a clot. That's just the way it is. Okay? So when that happens, it can go through the heart and up into the brain. It can go to your kidneys, can go elsewhere, but typically the first place it sees is the brain. There are other problems. Okay, there was a very famous case. Coretta Scott King had a heart attack, was surviving her heart attack, but her heart was so damaged it wasn't moving. It caused a stroke, and she died from that. We talked about heart failure. We talked about heart valve or wall abnormality. We talked about Ariel Sharon. Blood thinners in atrial fibrillation can prevent at least, and probably more, than 60% of all strokes. So that's huge. That's a huge number. Won't prevent all of them, but it can prevent a huge number. So it's very important to diagnose atrial fibrillation. And just in the last 2 years, what we found out is that when we do our tests in the hospital, we're only picking up about half of people that have atrial fibrillation because it can come and go. So your doctor may actually end up putting an implant of a heart monitor just under the skin, and you'll wear it for 6 months. And we may double the chances of finding atrial fibrillation that comes and goes by doing that. The reason it's important is because we put you on stronger blood thinners, which we don't want to do. Before, if we suspected it, we would put you on that. Some people would, not everyone. But there's risk. These strong blood thinners can cause bleeding. And so you really want to know what the reason is. Okay, any questions about kinds of strokes? Those are 3 big kinds. There's lots of other things. Yes? So that's a good question. An aneurysm is an abnormality of the blood vessel, and it has a weakness in it. Most people are born with the weakness, and then the weakness grows over time, and then it ruptures. So that causes bleeding outside the brain. It can cause pressure and leak into the brain and cause blood in the brain itself. But an aneurysm is not technically a stroke, but it's still important in the consideration. An aneurysm presents with the worst headache of your life. It's a rupture. The only part of the brain that feels anything is the lining. The brain itself doesn't feel anything. So the lining is damaged by that. That's why a typical stroke really isn't painful. But an aneurysm rupture is the worst headache that somebody ever had. Okay? And one of the symptoms that we'll talk about that you need to call if it happens. So what to do to prevent a stroke? So if you're middle-aged, at least get your blood pressure checked, every 1 or 2 years. If it's high, obviously much more frequently, and start treating it, and actually start treating it fairly early. The earlier the better. There's no symptoms of early high blood pressure. Unfortunately, if you're not getting a good response, the blood pressure is not lowering, then you may end up with more than one medicine. You know how many medicines we end up with. But this is one of those reasons, this is one of the better reasons to take more than one medicine. And sometimes we'll mix a lower dose of each one because then that reduces the side effects. Believe me, we hate to prescribe them as much as you hate to take them. Well, maybe not as much, but. And then address all the other risk factors you can modify, okay, with regular checkups. More aggressive treatment of blood pressure and cholesterol, especially if you have diabetes. You're more aggressive. We'll lower your cholesterol even more with higher doses of cholesterol medicine. Stay as active as you can, even after a stroke. It's extremely important. If something's limiting your activity, let's see if we can do something about it. If it's back pain, if it's knee pain, if it's, something that's keeping you from being active. Let's do our best to see what we can do about that. Healthy diet, it's not really clear. Vitamins add a lot to that if you don't have a deficiency. And it's easy to say healthy diet. Really, the Mediterranean diet is the one that seems to be associated the most with better outcomes. Lots of nuts and olive oil and those kinds of things. But at least healthy diet in moderation. The recommendations for fat and things like that are getting loosened more recently with the onset of all our medicines. But still, probably diet isn't unreasonable. Alcohol is very controversial. Everything in moderation, probably 2 or less in men, 1 or less drinks a day in women, although it's not clear it's beneficial. Probably more than this may end up being a little bit harmful. The idea that red wine is beneficial, I think, was always a little bit weak, and the evidence for that is getting weaker by the day. What about if you haven't had a stroke or don't have heart disease? Should you start taking an aspirin? Should you start taking cholesterol medicine? Probably not, unless there's some reason for it. It can prevent clots, but it also can cause bleeding, especially in the stomach. Probably okay in women if you have some risk factors. They seem to have less bleeding. Still not clear in men who haven't yet had a stroke or a heart attack. I'll tell you a secret, I take 1 twice a week, okay? But that doesn't mean it's good. That's just, I just do it, okay? Yeah, right. I'll tell you in a few years if that was good or bad idea. Study just came out that even if you haven't had a stroke or heart attack, but you just have a little bit high cholesterol, it actually helped reduce stroke and heart attacks. There are side effects. I'll tell you another little secret. I take a quarter of a cholesterol pill too every day, okay? But again, I don't know. I'll tell you in 10 years if that was a good idea or not. Okay, what if you actually have a stroke or you someone around you? In fact, the most common person to diagnose a stroke or suspect a stroke is a kid in the house or a spouse. Okay, those are more likely to figure you've had a stroke than you are. So know the warning signs, and all you really have to know is that any sudden decrease in function, I say change, but a stroke doesn't improve your neurological function. So any sudden loss of a neurological function is suspected to be a stroke till proven otherwise. Okay, and what are the typical ones? Weakness, numbness, inability to speak, to walk, a vision change, double vision, loss of vision, anything that is a sudden change. And even if it goes away, that's still either a 911 call or someone takes you to the doc in the box down the street. That's important. And then your question was a good one. We add to that that suddenly you just boom, you've just been hit over the head with a headache. That's very suspicious for an aneurysm rupture. Yeah, call 911. Right. Right. Sudden. You try to walk and you can't. So you can either not walk. The question was, what does that mean? Well, either you can't walk because your side is just so weak, but if it's in the back of the brain that controls your balance, you just suddenly are falling over to one side, okay? Not gradual, not all over the years, have less balance. This is boom. This is a sudden change in your ability to walk. Yeah, that could be a stroke. So don't wait to see if it goes away. Your question, good one. FDA has approved clot-busting treatment. Started in '95. It took forever to get people to come to the hospital fast. That's why these talks, were given for all the time. It's much better now. The window's been increased to 4.5 hours. The benefit goes down, but we thought there would be so much risk of bleeding that we just wanted to give it within 3 hours, but enough studies have been done that it is safe to give it to 4.5 hours, although the FDA has not approved that. So you probably will be asked to give consent or your loved one will have to give consent if they're going to give it beyond 3 hours. The benefit is not life-saving. It will not save your life. It will increase your chances of a good outcome. Okay? It will do that. And anywhere from 20 to 30% increased chance of a good outcome. So it is not a miracle unless you happen to be one of those that got all better. But it is still the best we have. I've seen just absolutely dramatic and remarkable improvement from this, and we'll talk about some newer treatments too. Unfortunately, only 2 to 5% of people nationwide get the treatment. It's huge in Houston. Houston has one of the best organized emergency medicine systems in the country. We're very fortunate for that. And it can only be given for that ischemic kind of stroke. Obviously, you don't want to give it for a bleeding stroke. So the first thing they'll do is see if you're bleeding or you have something that may bleed in your brain. Yes, sir.
How available is that clot-busting medication in rural
Yeah.
hospitals and so forth?
That's a fantastic question, especially in Texas. It is not as available as it should be, but it's improving dramatically through telemedicine. So what will happen is a small hospital, a rural area, will contract with a large, for example, at Baylor St. Luke's we have, 20 of these contracts at least. And then they will have a patient. All they have to guarantee is they have a CAT scan. They can do a CAT scan 24 hours a day. That they have to guarantee. And then they do the CAT scan. It'll get read somewhere else, and they'll be instructed to give the clot-busting medicine, and they'll come in. That is still covering only about half the rural areas. There's still a big gap. The state has funded a big research program, and we're part of it, to do research in telemedicine to see how we can improve that. But I tell you what the other problem is. The other problem is they don't get good follow-up care either. So even if you give this medicine, a lot of these places, they go home and then they come back a month or two with some other problem. So it's a big issue, and fortunately the state has seen it to fund the big med centers to look at how to best help them. I've flown down to Harlingen. I've been there. You'd be amazed how much work they're doing in Harlingen. It's great. We have a site out in El Paso. It's getting out there. It's getting out there. And Texas is really leading this to try to get it out there. But, I have in-laws that have a ranch about an hour outside of San Antonio, and they're getting on in years, and they ask me, where do I go? What do I do? I'm literally in the middle of nowhere. So, yeah. Yes, ma'am.
If you live close to the church and you think you or your husband or someone is having a stroke, should
Right.
you say, take me to so-and-so hospital at the medical center because this is where my internist is.
Right. You want to come to Baylor College of Medicine if you have a stroke. No. So how that works is, I'm not here to advertise. So how that works is the Houston ambulances, and we have a meeting every quarter. All the hospital directors, there are 31 stroke centers in Houston. It's incredible. They've really stepped up their game. And the ambulances have a chart of how long it takes to get to which hospital. Okay, I think they include traffic in that. And if your hospital is fully equipped and you have a severe stroke, they may bypass a little hospital to go to a big one. Okay, they may do that. But even the little ones can give the clot-busting drug. So it covers the loop, inside the loop, outside the loop, Woodlands, all of that is covered. You're well covered in Houston. Fortunately, it was a lot of work. That didn't just happen. But the EMS director, phenomenal, David Purse, just a phenomenal. He actually worked in stroke, worked in emergency rooms, became interested in stroke, and now over the last 20 or 30 years, Houston has just been remarkable. And they will take you. Now, if you have a doctor at a certain hospital, you can request that, but then they'll check their list. And they say, I'm sorry, they're really not one of our stroke centers. I have to go somewhere else, yeah. And that's a law. That's a state law. They can't violate that law. Right. Yeah. Don't worry about whether it's a stroke or not. It's better to be safe than sorry. Okay, we're used to that. I get probably 5 stroke pages for every one that's actually a stroke, but that's what they pay us for. Okay, that's why we're here. Houston, as you already anticipated this, has these stroke centers, and the EMS know these very well. Okay, after your stroke. So there's no other message you take home is you need to know what kind of stroke you had. If you know, this is not a given that every physician thinks about stroke this way. Okay, so this is incumbent on you to make sure that they're designing that care for the kind of stroke that you have. And what are you doing together to prevent another stroke? Remember, you have to try to be active. You have to take your medicines. You have to follow your blood pressure. You have to be aware of the warning signs. And you have, so, you know, there are things that both patient and doctor and, you know, nurses and the whole group can do for that. And you make sure that the preventative treatment is designed for the kind of stroke that you actually had. Okay? Questions about if you've had a stroke, someone around you. Don't be shy. Yes? Uh-huh. So they probably did an MRI maybe for something else? Okay. Yeah. Aspirin. She should have, I can't. Everybody's different. But in general, in general, when we see those mini strokes, and as I said, there may be many there, is in general we would say yes. That is it more than we'd expect for someone's age? You know, for example, maybe it isn't for this person. Maybe it wasn't more than they expected, but you'll get a full, and you'll get what we would do is there are sort of common things that can increase your risk of stroke. For example, low B12 actually increases the chances of hardening of the arteries. I can't tell you how many B12 deficiencies we found in our stroke clinic. Which is a long-term risk factor. We look for inflammation in the body that some of these medicines may help with. So yes, in general, if you see more than you think they should have, one would get more tests. Yeah. Either neurologist or primary care. Cardiologist, not yet, not unless there's really heart disease. But since there's a brain that was being looked at, primary care. There is something called vascular medicine. If it gets really tough, then there is a third specialty called vascular medicine. For example, if we just can't control your blood pressure. But that sounds much more routine. So in a more routine case, that's what we would do. Okay? Were they upset with the news, or was it? Yeah, and didn't feel like an... Oh, yeah. Yeah, it's funny how that works, right? Right. Aspirin is a powerful medicine, so, you know, it is not a trivial thing to recommend somebody start that. It's not as if that is nothing. I mean, it seems trivial because you can just do it yourself, right? But it's pretty powerful medicine. It'll reduce by about 25% the chances of another stroke just on its own. Okay. So what are some new developments in the last few years? So we mentioned this with your question about the timing. Along with the clot-busting drugs, which you give in the vein, and this has taken more than a decade to refine, but there's a new kind of device that you take a tube called a catheter. Many of you be familiar with that, especially from the heart. And this is a device that actually pulls the clot out. And it does it without a lot of damage. There were devices before that, but they were a little bit trickier to use and didn't end up showing overall benefit, although some patients benefited greatly from the older devices. But these things we call stent retrievers have just been an amazing development. And these we can give by FDA approval and by some support from studies even up to 6 or 8 hours, but only if your CAT scan doesn't yet show any swelling from the stroke, okay? So if it's a big stroke, probably won't be eligible this far out. So still, the sooner the better. But what you'll do now is you'll come in, you'll get your medicine, and we'll immediately look at your blood vessels and see if you have a clot there. You'll just be wheeled everywhere. The newest emergency rooms have everything right down there. But most hospitals, you still go up an elevator, or you go, down the hall or something like that. But this is an amazing logistical feat. One of the things our state money is using research is how to improve the timing. Can we take smaller hospitals aren't used to this and make things go even faster? Okay. In one study, if you got both the clot-busting drug and this device, you had a 70% chance of a good outcome. That's just incredible. I mean, think about that. Big stroke, and you have a 70% chance of a good outcome. That's the clot-busting drug. Yes, that. I did this at the last minute. I shouldn't have said it that way. Okay, other new discoveries. So we talked about the swelling. Now, this is a little gross, I'll warn you. You talk about the swelling, right? So Richard Nixon had that, passed away from it. Swells like any bruise, but that darn skull just keeps that swelling in place, okay? Well, let's take the skull off, okay? They will actually take half your skull off. Put it in your stomach for about 6 weeks, let your brain heal, put it back on. You wear a hat, yeah. I told you it was a little gross, yeah, outside in the lining, yeah. You just cut it and you put it in there, yeah. Yeah, keeps it healthy that way. Removing the skull helps improve outcome. And it's major surgery, so Nixon may not have agreed to it. We still don't know exactly when to do it, and so there may be discussion, but if somebody is in the hospital, they had a big stroke, it's a very worthwhile question. Are they eligible for having this procedure done, called hemicraniectomy? Okay? So it's worth asking about it. Now, there's some new research that we are involved with that's coming mostly out of Baltimore, but we helped with the analysis of maybe why would it be promising. It turns out that a medication used for diabetes called glibenclamide or glipuride's a trade name, actually works on that cell to prevent the fluid from going in. It's an incredible effect. Just by nature, for some reason, put the same binder to the medicine in the pancreas to control your blood sugar as it did in these brain vessels. Why that happened, who knows, but it's a remarkable discovery. And so this medicine was just studied, and it reduces the chance of death without the brain skull coming out by 40%. So this is not approved yet, but it is very promising. I'm sorry. Glibenclamide. I think it's spelled right. Actually, I don't know if I spelled it right. I did it by phonetics. Most of you know, if you have atrial fibrillation or know somebody, that there are a variety of new medicines to prevent stroke and atrial fibrillation. These are medicines that are in addition to warfarin. Warfarin is still great, but some people just can't regulate it. And so if you can't maintain it right, it's not doing you very much good. Maybe that's what happened to Richard Nixon. His blood got too thick. It's hard to regulate. I don't know. That hasn't been reported. But these newer ones, you don't need to monitor. There are several to choose from. You'll see them advertised all the time. Some are better than others. If you have kidney disease or age or some other kind of problems, we might pick one over the other. But it's really good news because it's so much easier on you to take one of these medicines. Now, there are some problems. If you stop them quickly, they act quickly. Coumadin takes a long time to work and a long time to wear off. These medicines will stop working very fast. So if you stop them on your own, there is a chance of a heart attack or stroke just from stopping the medicine. So, we try not to stop it on your own. If you're bleeding for whatever reason, only one of them can actually be reversed with a new medicine. Coumadin can be reversed. So if you're bleeding and you're not on this one, We just have to take time for the others, but because they act so quickly, it's actually not that long. It's about 4 to 6 hours, but you're sort of helpless in the meantime while that's happening. But fortunately, the bleeding is 2 to 3%. It's not very high, but if it's you, that's 100%. Okay, questions about new things? I just want to spend a few minutes on recovery, and then we'll answer any questions or let you go. So our goal is to have you lead as normal a life as possible with whatever deficits occur. Therapists should work with patients. If you don't feel you got enough therapy, there are unfortunately a lot of rules about how much therapy someone can get. But when they get it, it should be good. In other words, they don't just wake you up and say, oh, you're too sleepy for therapy. You should come back when you're not sleepy and give you your therapy. There's occupational, there's speech, there's kinesiology. There's all these therapies that are absolutely beneficial in recovering from stroke. Motor function tends to recover quicker over the first 3 to 6 months. Language, if you lost language from your stroke, that may continue to recover for years. So what I like to do is have the speech therapist reassess people. Reassess people over time, because it may be some speech things have come back and the person can communicate a different way than they could even 6 months before that. So I'm not going to give up. We're going to keep reassessing you. And there's always fundamental research that's occurring to try to improve how the brain rewires itself to recover from stroke. One of the more promising ways is to force you to use something that's not working. People will typically revert to using the other side to compensate. We may actually force you to use the arm that you don't want to use, for example, or even in speech, may force you, rather than using gestures to communicate, to force you to speak. I mean, I can know a few French foods, but when I get to a French restaurant and it's time to order, I still point, okay? So if you're a stroke patient and you don't speak very well, you may try to do everything but speak, and we might actually force you to try to use your speech to recover. So there is some hope, especially for hands, leg, and speech. Okay, that's it. Thank you very much for the invitation, chance to talk to you all, and I will answer any questions you may have. Yes?
One more.
Sure.
Your comments about where EMT is instructed to take patients.
Yes.
If someone in your family, you observe them having a stroke,
Right.
given the time frames that you set up, would you instruct them to take that patient to St. Luke's or Methodist, or to the nearest qualified stroke center in the city?
Absolutely the nearest stroke center, because getting that clot-busting medicine into you fastest is still the most important thing. And there's a little bit of controversy about that. But we just presented a study, and actually was in one of the current neurology press magazines, that if you get your TPA, then after that, to get these fancier treatments that need to be in the bigger medical center, you do better if you got your TPA, okay, if you got your medicine. So that's where we stand. That's where the EMS is currently, okay. Now, if they suspect, they will bypass the little hospital if it looks like a hemorrhagic stroke to them. They will bypass because they probably don't have the neurosurgery and things available to them. But that's what, does that sound like a reasonable answer? What do you think of that? Does that sound okay? Yeah, I think that's what we would do. Doesn't always happen, but that's what we would do. Sometimes it's minutes. If it's only minutes, yes, bypass it. I mean, if it's 5 minutes, that's not going to make that much difference.
How do they know it's a hemorrhagic?
Good question. They get training. There's certain signs of a hemorrhagic stroke. With a hemorrhagic stroke, you lose consciousness quicker, okay? It's more severe. And so if they suspect that, because that's early pressure in your, I won't go into the details, but that there is a suspicion. They actually have these scales. It's amazing what they're like 20-year-old kids, and they've been trained in this on a regular basis. So that we've all agreed. You might go ahead and bypass somebody if you think it's like that. Now, we have a few fights about this. We do fight a little bit, but it's all working out fine. It's amazing cooperation. In fact, the Texas grant is the UT schools, Baylor, Texas Tech. I mean, we're all cooperating with each other, which is the way it should be. It's incredible, the resources we have in this city. Anything else? Yes, one more? So memory loss is not the most common symptom of stroke, but certain kinds of stroke hit only the memory centers. It's really rare. So it's rare, but it's dramatic when it can happen. And it can cause confusion because you just can't even remember anything. But it's not the most common symptom.
Does it affect just like memories from your past, or will it affect like retaining?
More the retaining. This kind of stroke will more affect your retaining new things. And that's why you get so confused. Yes? Atrial fibrillation? No, heart murmur can be anything. Can be totally nothing. It can mean some valve problem. Atrial fibrillation is your pulse. It's irregular. It's just fibrillation means it's just coming and going and it's not regular. Okay, those are two different things.
You didn't mention beta blocker medicine anywhere in here.
Blood pressure treatment. That's one of the blood pressure treatments. Yes, right. All right. Thank you very much.